We are gonna go event and practice session. Here we go. Okay.
All right. Good evening, everyone. Dr. Kuo, I believe has said that we are live, so we are excited to have you here this evening, or wherever you are, whatever time of day it is. I'm John Russell from Johns Hopkins Hospital in Baltimore, Maryland. Today we have a very distinguished panel of really, arguably, some of the most cutting-edge individuals in the world when it comes to managing thyroid pathology. And today we're going to talk about the cutting edge of the cutting edge, specifically the road less traveled and how we manage this. As our co-moderator, we've got Dr. Imad Kandil, who is floating somewhere through the streets of New Orleans as we speak. Of course, he's a professor of surgery at Tulane University in New Orleans, and he tells me he's okay, and he's told me that at least 5 times in the last week. So, Imad, we're going to hold you to that. We're glad you were able to moderate with me.
Thank you, John.
Today we've got, as part of our distinguished panel, we've got Dr. Marius Stan from Mayo Rochester, who is a consultant in endocrinology and really one of the early leaders in the United States of radiofrequency ablation, which is, of course, why you all logged in tonight. And he'll be talking to us and sharing a case about radiofrequency ablation for papillary thyroid cancer. Dr. Leonardo Rangel is the chief head and neck surgeon for the State University of Rio de Janeiro in Brazil, and he's also a member of the American Head and Neck Society Technology Committee in the endocrine section, and he's a very good friend of mine. And we are hopeful that Dr. Tim Huber from Portland, Oregon will be logging in with us shortly, because he is an interventional radiologist who really has taken the lead. I think one of the exciting things about this panel and about all of anything to do with radiofrequency ablation is the collaboration that we have across disciplines and really across the world. And so we're excited that you're able to tune in this evening. And without further ado, unless Dr. Kandil has anything to add, I think we can turn the time over to Dr. Stan.
Thank you, John. Imad, thank you. Happy to be here with all of you. And I imagine sound comes okay. Can I see a thumb? Yeah, all right. And it is a pleasure to participate in a conversation about where RFA is going and what it can offer to us and our patients, or the other way around. And the area that I think it's burgeoning in the use of RFA is that of what is its role when we talk about small thyroid cancers, and in particular papillary thyroid cancers. I hope that I can advance this presentation, and that's going to be probably there we are. The technical challenge will be bigger than the RFA challenge, I think. But when we looked at the issue of what might be the role of RFA in thyroid carcinoma, we decided to look at the area that has in recent past turned out to be spectrum of choices, and that is the micro PTC. So papillary thyroid carcinomas up to 10 millimeters. Some of these need to go to surgery. They're either associated with local or distant metastatic disease. They show signs of invasion. They have a histology or a cytology, I should say, that is very worrisome, or there's been fairly recent progression. I think in those cases, our management still has to be the conventional one of using surgery. But in cases that do not meet any of those criteria, I think there are some alternative ways of managing PTCs, and this would be in agreement with what the ATA has outlined a few years back. So these cases that are presumed to be a low risk is what we've taken on a few years back, and rather than go to one case, I'm going to tell you we did 5 such cases and I'll sort of blend them together into a one group. This is a little bit of a schematic of how we monitor this patient from early on after ablation within the first 72 hours, a month out, 3, 9, and we're somewhere with all these cases somewhere between 9 and 18 months. And I won't go into the specifics. We'll have time for discussion. I think what I want to bring to the group tonight is share what we thought are reasonable inclusion criteria and exclusion, because that's where I think it'll be a bit of a debate. So as I said, we went for papillary thyroid carcinomas and specifically excluded any other histology, follicular or medullaries. These had to have clear evidence on cytology of documented as opposed to suspicious. We put the cutoff at 10 millimeters for these cases. And we made it clear that for these cases to qualify for RFA, there would have to be acceptance from the treating team that observation, so active surveillance as it's called by some, would be an acceptable alternative. Those are cases that we consider for RFA. And then obviously from a technical perspective, they had to be easily accessible for a thorough ablation. And while the inclusion list is short, you'll see that our exclusion list is much longer. Basically, what we tried to exclude was anything that suggested a risk of multifocality. So if there was a genetic cause like familial adenomatous polyposis or Cowden or Carney syndrome, those would not be on this list. Concerning nodules on the contralateral side or adenopathy, presence of anything that would suggest distant disease, pregnancy goes without saying, prior interventions with cord paralysis on the contralateral side, issues with coagulopathy status, prior neck surgery or radiation, and you can see a few of the other issues that are listed there. So once we looked at these cases, I guess it'll be a bit of a challenge. This was meant to be a sequence of images. I don't know if we can bring them one at a time so you can see 3 of the 5 that we included. Well, let's look at the very last one that you see here. We wanted, and this I should say, we the way we work here in Rochester, the endocrine component is the one selecting the cases. The interventional radiology is the team that performs the RFA, and then we have anesthesia on these cases. So it's a collaborative effort, but the idea was to select cases where we do have clear thyroid parenchyma surrounding these lesions so that we can perform a ablation into the surrounding territory with a buffer zone of at least 2 millimeters outside of the nodule. So you can see one such lesion that was targeted. I can try and likely will fail to open this PowerPoint so that you can see the other lesions, but they are similar in appearance. And this one you see was up to a 10 millimeter mark. We had one at 12 millimeters. That was the maximum lesion, even though our goal was to stay within the 10 millimeter mark. These 5 patients were treated all in 2020, and I'm going to bring up for discussion what I think was one element that should not be a surprise, and this is what happened with thyroglobulin post-ablation. You can see the baseline thyroglobulin, and in the orange line, what you're seeing in the yellow line is actually the thyroglobulin antibodies. And we wanted to collect these prospectively because it'll make a difference down the road, not necessarily immediately after the ablation. And no surprising, we see the thyroglobulin pre-ablation and post-ablation arise, associated also with developing of thyroglobulin antibody. This is one of the cases. And very nicely to see that at about 10 months post-ablation, the thyroglobulin finally comes lower than the pre-ablation values. And this, I think, mimics what we expected and what we saw on the, let me take another image. This is the post-ablation image at 10 months of the 10 millimeter nodule. And you see that the maximum dimension is actually 18.6 millimeters. And this was collected just recently on the case that was at 9 months. So 9 months post-ablation, we still have a significantly larger lesion, or I would say ablation footprint, than the nodule itself, which we had internal discussions as to, here's another, let me see if we can get a this is another longitudinal, but you can see the Doppler on this image, and reassuringly a very low color Doppler flow, just a little bit at the periphery there. And I thought it would be helpful. There's the transverse view of the same lesion. This was a benign nodule that you're seeing here, more anterior biopsied benign, not a concern. So I wanted to bring up our internal discussion about being very careful how we judge these lesions post-ablation, because we expect them to be larger, but how long will they be larger? When do they start to shrink? So I think that this graph is helpful to turn it back to the moderators. This is a graph that I took from Dr. Bayek's team report just last year, looking at 5 years out experience with volume of PTCs ablated. And as I'm sure all my colleagues know, the vast majority of those lesions ended up being undetectable from 2 years out. I think this was 90-something%. And at 3 years, it was almost all of them were undetectable. But this was consistent with what we were seeing initially from a perspective on the y-axis. You have volume reduction. You can see that actually the volume increased up to 200% at the 6-month mark. And only towards the 1 year out, it finally showed the volume reduction. So internally, we were feeling reassured. We were reassured by the vascularity, reassured by the decline in thyroglobulin. But I think it's an important point to make. What will happen with the volume and the biochemistry of the thyroid during the early phases, early months post-RFA? And I'll stop here and turn it to John and Emad to carry on from here.
Thank you, Dr. Stan. That was a great synopsis and really a great review of everything. Emad, I've got a bunch of questions, but do you want to start off?
Well, thank you very much. That's a very impressive presentation. I wonder, do you think really the thyroglobulin will help you with your decision making? We know if you just do an FNA of a thyroid nodule, this will bring the thyroglobulin up. And I really don't know I don't know if anyone knows what's the difference between RFA versus FNA for how high the thyroglobulin will be. But do you have any idea about the value of the thyroglobulin level in relation to the RFA?
Absolutely. I agree with you that thyroglobulin in the early months should go up. Exactly to your point, we've seen thyroglobulin going into the thousands after some procedures. But I think what is helpful is just like after a lobectomy, to establish a baseline, because if we're worried in some cases that there'll be distant disease, there has to be a baseline from which you can get a sense, is this marker staying in the same territory? So if 10 goes to 15, it doesn't worry me. But if 10 goes to 100 a year later, how would I be able to gauge that something might be spreading beyond the ultrasound imaging? So I think establishing a baseline is what were trying and being researched. We wanted to have the numbers. It's not that we were looking for metastatic disease, but we wanted to be able to draw the curve, what happens to have a future plan, when is the thyroglobulin back to baseline, and from where we should use it as a maybe a reassuring marker that there's no distant spread. If that answers the question, if
No,
I
yeah,
can go.
absolutely. And for the last case that you presented, I saw that the nodule is a little bit towards the area of the dangerous triangle and where the nerve enters. And as you know, there are some few reports of few cases in the Kuma hospital experience with active surveillance where there's like some invasion of the recurrent laryngeal nerve with the micro PTC. And I was wondering, does like having the nodule in this territory will make you stay away? I was really surprised that you are doing that.
So the only image that I showed of the PTC, or the one that we can see here, is this one. And as we were looking at all these lesions, on all of them, we felt that we have 2 millimeters of surrounding parenchyma, at least 2 millimeters, I should say, of surrounding parenchyma. In one of the cases, my colleagues have used hydrodissection, which I should say, actually, the patient complained of a lot more discomfort than the other 4. But we were within, I think, the margin that we intended to be. We have not seen any voice changes in any of these individuals. And as far as our future approach, I think that we will probably drop the limit to just 10 millimeters, as I was saying earlier. That 12 millimeters, we were a bit concerned that we've gone beyond what we intended to do. It's an evolving
Actually,
field.
very
That's as much
interested
as
in the
I can
comment
say.
that you made about the hydrodissection, because I really feel this, like not every single case needs a hydrodissection. Like the case that you showed, the nodule is far away from the capsule. And if you do hydrodissection in that specific case, all what you're doing, you're pushing the entire thyroid down, including the nodule, towards the dangerous triangle. And I don't see any value for the hydrodissection in that specific case. It makes it actually, this is my opinion. I wonder what the rest of the panel think. It makes it, as you said, the patient had more complaints about maybe the voice. I think you bring the nodule more close to the nerve, and it doesn't add anything. I think hydrodissection is good when the nodule is near the capsule. This is where the nerve supply is, and this is where the patient will have pain.
I'm with you on that. Yep.
Yeah, I would agree. I think I've probably used hydrodissection a lot more sparingly, and I'm hesitant to say that it's because of the value of hydrodissection or versus my skill set, you know, because when I watch Dr. Beck do it, certainly he uses it quite liberally and to very good effect. Tim, Leo, any comments?
I tend to use hydrodissection very often. I think the amount of liquid that you put in really depends on what you're really trying to do. And sometimes if you are outside of the hot spot, that the liquid really spread over the capsule, sometimes it can deposit just in that small area and do not diffuse around the thyroid, and you get a bump in some areas, and it's not that what we necessarily want. Sometimes close to the trachea, not necessarily using the lidocaine, but I think when you're over the capsule, when you use lidocaine, really gives the patient some comfort. But close to the trachea, if the nerve is close to the dangerous triangle, you are going to use 5DW, and that you need the volume, and the volume can really make the patient a little bit discomfort.
Those are great points. I try to use dissection, when I can, but it can be difficult to control. You do get some of that puddling in certain locations, and you can't always control the spread. And so it does take some skill and some luck and some finesse to be able to use it, I think, as well as we've seen it in some webinars.
So
skill and luck. Yeah, that's exactly
better lucky than good. Tim, we introduced you a little bit earlier, but we're glad you were able to get through the WebEx. Of course, Tim Huber, Assistant Professor of Interventional Radiology at Oregon Health and Sciences. Glad to have you with us. There's a question in the chat, and for anybody that's tuned in, please use the chat function to ask any questions. Dr. Kuo from NYU has pointed out, I'm sorry, from Columbia, sorry, Jen, I know you're listening there. It is pointed out that it's, she has also noted that as she's ablated these lesions, these small microcarcinomas, that she's seeing changes in size. And the question that she has is, do you think that it has to do with the area that we're treating around the cancers? And I was actually going to ask you about the same thing. What is your rim technically? How far beyond what you can see sonographically are you treating? And do you think that contributes to the size changes?
Absolutely. No, John, it's on purpose, as we all know, that we do not want to stay subcapsular on these nodules as opposed to a benign nodule, or at least that has been the distinction that we made here, that if we aim to treat thyroid carcinomas, then it has to be a thorough ablation with a normal parenchyma, which we aim to have at least 2 millimeters surrounding the nodule. So it is expected to have an increase in volume. How will that play out and for how long before you see the shrinkage that we all look for? That is what we're trying to define. And I think that the 2 millimeter is something that we've seen in Southeast Asia being employed in a number of studies from Dr. Beck and also from China. We're learning, we're trying to reach the same outcomes, but obviously the anatomy of every individual will make it more or less difficult to achieve those 2 millimeters. So that's what has to dictate if this is a feasible option for every micro PTC, or if we should stick with those that allow easy access to at least 2 millimeters of normal tissue around it.
Thank you. I've got about 50 other questions, but I think we probably should move forward and then we can come back to them at the end. I think up next we've got Dr. Hangel is going to present a case of his of papillary thyroid microcarcinoma. Leo, take it away. Dr. Stan, are you able to stop your presentation? Maybe Dr. Kuo.
Once I start, I can't stop. No, I'm kidding. That has been the challenge that Leo and I were having, trying to swap presentations. And I think if you go ahead, Leo, you should be able to take over.
Yeah, just a second.
Well, while we're doing that, just a technical question. Oh, never mind. We're good.
No, go on, Russell.
Success. Take it away, Leo.
Perfect.
Giving Bertelli some screen time. That's good of you. I think you're muted, Leo.
Sorry. Where's?
You're good.
No. Okay. Thanks, Russell, for presentation, Jen, and pleasure to be here with Imad, too, and Tim. Well, I want to start showing a case so we can discuss over this. This is a 34-year-old female, euthyroid without any comorbidities. She was trying to treat infertility, and then she investigated her thyroid function and found a small T-RADS 5 in her left lobe. So this is the image. This is the ultrasound that they send us. I really, this image, I was a little bit concerned about extracapsular invasion, but under my ultrasound, it didn't show that too much. So it is a very small lesion. And the guys decided to biopsy it because of her fertilization treatment. So it came back AB test of 6, and she didn't have any lymph nodes in her ultrasound. So we showed her some options. We showed her active surveillance because it was really small lesion, and albeit close to the capsule, it wasn't really invaded or worried about this in the ultrasound. Of course, we offered her a lobectomy, even open, tuituva, or robotic, thinking about not having a scar or trying to minimize the post-operative aspect of the surgery. And we offered her ablation. Of course, because for the sake of this presentation, she took radio frequency. And actually, this is her image. So this is the procedure, and this procedure, you see this image backward because I do the procedure over the patient's head. So I turn the probe. So what is left, it's like right. Okay. So you can really see the image of the nodule, and we didn't see any lymph nodes, and we can really see that we don't have a invasion. We can see the capsule preserved at all times. Okay, so we moved for the ablation. It's really what Dr. Stan said, and as this is a small lesion, we could easily target the center of the lesion and try to ablate it entirely by the center, but I decided to give a margin. So even this small lesion, I did 2 spots. So I tackled the superior part of the nodule and the inferior. So, and we see here that I really take my time to do this ablation. I don't use the same, we actually decrease the power. Generally, I use 20, 30 watts instead of the regular 40, 50 watts that I use in benign nodules. And I really leave it there in order to take the time to really ablate and ablate the nodule and a safety margin. So here I use the ablation, and I took also some muscle. So I really ablate the muscle over that thyroid in order to give a margin of ablation. And that's why I think it is important to do the hydrodissection, so the patient can comfortably take the procedure. So here, sorry, I did not edit that much. And here the inferior part of the ablation. It was pretty fast forward, so this procedure took 9 minutes, but actually could have taken a little bit less time than this. Okay, so it is just about this. And the follow-up, as Dr. Stan said, we experienced a huge increase in size after the procedure. So here we see a lot of edema. We saw alteration over the thyroid capsule. We can really see that the image is quite frankly scary. Here we can definitely see that the ablation zone inside the thyroid and outside the thyroid, that the muscle over the thyroid was a little bit altered with some fibrosis. After the 3rd month, we cannot see any thyroid lesion anymore. We only see the alterations of the muscle, and here we can really see just the scar, the indentation of the muscle over the thyroid, and without any vascularization. So this is what we can expect in a regular case. So this is a pretty straightforward case. I would like to show you the pretty easy case that we decided. And we did not prepare this together, but I think this the questions that I ask is that I raise is something that after following the Dr. Stan's presentation, and actually when we look for the risk of recurrence, we're not talking about the risk of death or those micropapillary recurrences, but actually when we think about recurrences, and we are treating patients in the lower part of this slide with intrathyroid unifocal lesions with minimal invasion, we are talking about the worst case scenario, a 3% scenario of recurrences. So when we have diseases like this and we face a treatment, standard treatment like thyroidectomy risks that range from a scar, that is something that we face in most of our patients that are nearly 100% of the cases, patients will end up with scar unless they go with a scarless approach. Some patients will have a bad scar, an unsatisfactory scar ranging from 10 to 15% of the cases, and some cases of real problems after surgery. So in this paper, the group A is total thyroidectomy versus group B is total thyroidectomy with central neck dissections. So we have up to almost 20% of temporary hypoparathyroidism. We have almost 5% of permanent hypoparathyroidism. We have vocal cord paralysis temporarily in 1%, and have some hematomas. So our procedure have risk factors that have complications that ranges above the risk of recurrences. So we really think we need to be cognizant about this when we show the patients their options. So, and this is also an interesting paper that compares the complications of surgery when the patients were immediately referred for surgery versus when they were observed, then offered surgery, need to go to surgery. So even in that scenario, the chances of complications are smaller, probably due to selection. But anyway, these patients, as Dr. Stan said, that were offered active surveillance could easily go to radiofrequency ablation. So we can really see that being the case of not increasing the risk of complications on surgery after, if we need to operate on those patients. So I will raise some questions that we need to face when we talk to RFA. So if RFA really kills all viable cells, neoplastic cells, so if it prevents progression, if the lymph nodes will not be, we don't see progressive lesion in the lymph nodes, if it's as safe as active surveillance, or if it is as safe as active surveillance followed by surgery, if it can replace active surveillance, and in the extreme scenario, if it is as effective as surgery. And finally, if we should offer it routinely for patients in all scenarios. So I think these questions are really in our minds right now. So I think we should take our time and discuss it. I'd love to see your opinions on this.
Great presentation, Leo. Thank you.
Well, Leo, this was impressive. I actually saw this case. Lisa Orloff presented your case a couple of weeks ago in one of the American Head and Neck webinars. And as you can imagine, a lot of surgeons there who are not an RFA, like, supporters, but you can't argue with this. The cancer is gone. It's just like, wow, so impressive. So I have actually, so I'm definitely, to answer your question, I think this is an option that we should offer to patients, absolutely. But I do have two questions. First one, maybe just a little bit technical, and the second one, I would like to hear from the panel their opinion on this. For the technical question, you mentioned that you want to go slowly and you go down in the power. So my question to you, how do you make that decision in relation to the size of the needle, like 5 millimeter versus 7 millimeter, for example? And do you depend on the bubbles or you depend on the impedance? And how, what do you mean? Can you tell us a little bit about your thinking about going slow here? Thank you.
Perfect, Imad. Yeah. You are totally right. When we use different size of active tips, we need to be cognizant that when we are reducing the size, we are increasing we're decreasing the area that we treat. So we concentrate the amount of energy that we are delivering. So it is very easy. It is easier for surgeons that we use those bovies, that we use the regular tip, and sometimes we use the needle tip. And when we use the needle tip, we have to decrease the power of the bovie. And it's the same way of thinking. When we decrease the area of that of the active tip, we need to decrease. Otherwise, the amount of energy, the area that we are going to deliver is going to be higher. So if we change from a 10 millimeter active tip to a 5, we at least should decrease to a half of the power that we are using.
Agree.
Yeah, and when we are treating these small lesions, and it's easier when the ability of the generators that we use for radio frequency ablation of thyroid are different from the ones that we do other lesions, especially because we can give higher power than from other generators. And why do we need to, why do we use higher power? Because when we deliver higher powers, we rapidly create an area that the impedance increases and we block the energy. So we have an area that is more controlled. We do not spray the amount of energy around the tissue. When you need to go further and when you need to go for larger areas, you have to decrease the power and leave the heat sink effect to do his job, and enables the area of ablation to increase. So in order to have a larger area of ablation, you need to stick the needle, leave it there, and let it burn. So let it boil. So so with 1 or 2 areas and low power and leaving for like 1 minute, for example, you have a larger area of ablation instead of increasing the power and moving a lot. So you will end up having more work to do that area. So that's the way I think. For 5 millimeter, I would argue to use 5 watts. If you're using like a 7 millimeter, you can start with 15 watts, for example, and go up if you need to, you know.
How about the impedance versus bubbling? Do you depend on bubbling or impedance to make pull out?
Yeah, when you have this is a solid lesion. So when you have bubbles, you went a little bit too far. When you have bubbles, you hit a little bit over 100 degrees Celsius, and you have boiling tissue. You don't need to go that far. If you have a hyperechoic area, you did fine. You don't need to see bubbles to do your job. So a little bit before the bubbling, I think it's the best area. When you use lower powers, you decrease the chances of having bubbles because the area is spraying slowly, and you have a more homogeneous ablation area instead of have those bubbles. Because when you have the bubbles, the impedance increases. You don't have this area anymore. So when you're doing large nodules and you really need to be cognizant about these areas that you're ablating, the higher energy works very well. It's better than when you do the moving shots technique. But when you're treating these small lesions, it's better.
I agree with all this. This is very impressive. What impedance do you start to pull out?
I don't have a number because we don't have you cannot predict the starting point. So when we can have impedances starting from 100, 150, or if it is an very old person, you can have up to 200. And it's up when you have the really increase. You see it increasing for 50, for example, ohms, and then go to 100 ohms, and you don't need to. And the equipment shows that as the impedance increases, the power decreases. So when the power decreases, you're not doing very good job. So it actually is it's counterproducent. So it's better to stop and move that area.
So John,
I don't have a number.
Okay, very good, very nice. Thank you. One quick question, John, for both Leo and Marius. Do you guys do BRAF for these lesions that are sub-centimeters? Does it make any difference in your decision making?
I don't think so.
I would not. I don't think that it somehow overcomes the assessment that you get from pathology. So some patients will come with the genetic test already completed. I might factor that in if it comes to a lesion that would require total thyroidectomy and then a decision about radioactive iodine. But if it's a micro PTC and it is fully intrathyroidal, I don't think BRAF will change the management.
Thank you.
There are so many good questions that can come out of this. I think why don't we get to Tim, and then let's try and wrap things up by an hour, and then we can sit on here and keep talking for anybody that wants to stay for another 4 hours and hash out everything to do with all of that. Leo, that was great. I know, just like Imad said, technically that was very valuable. A lot of that information that you provided, lots of questions. Tim, I know you had a case of recurrent papillary. Do you want to kind of take us through this a little bit?
Yeah, let me get this queued up here real quick. Sorry, somehow it jumped ahead to the end. Computer's been acting funny today. All right. So thank you, John and Imad, for moderating this. I know it's been a little bit of a hectic past week for you guys on the East Coast there. But hopefully everyone's safe and doing well at this point. So in this Road Less Traveled talk, I wanted to present a case that's a little bit different, but in the same vein. In this case, it's a case of recurrent papillary thyroid cancer. So just a little bit of background for our program at OHSU. We're new to the malignancy world in terms of treating thyroid cancer, but we've been growing for about, this is our second year of operations. We're closely tied between the IR department and the Thyroid and Parathyroid Center here, and this multidisciplinary group, including a couple of surgeons and a couple of endocrinologists and myself, who work together to kind of screen patients and make determinations on who would be appropriate for these treatments. And mostly been doing benign disease, but we're starting to move more and more into cancer patients and evaluating some for potential RFA. So one of the first patients that we've treated is a 71-year-old male. He had a history of left papillary thyroid cancer and very long history. So we initially started off in 2015 when he was diagnosed and had a total thyroidectomy and left neck dissection and actually had 8 out of 8 nodes positive. So then underwent RAI. Did well for about a year and then had some enlarging nodes, biopsied, again, had neck dissection, clean out for positive nodes. 2 more rounds of RAI in the intervening years in 2016, 2018. Did well for about 2 years and then had some enlarging nodes yet again and was found to have a positive level 3 node, one in the thyroid bed, and then some lung nodules. And we discussed his case, as a group and with his outside oncologist, and sort of discussed different options. And ultimately, they wanted to refer him to discuss RFA. And so here you can see these two nodules that we're talking about in the left level 3 region, abutting the carotid. You have this sort of, it's a little indistinct, but this hypoechoic nodule sitting right along the carotid. And then here's the FNA we did of the lower thyroid bed nodule. You can kind of see, again, enmeshed pretty close to the pretracheal tissues here in the bed of scar tissue in the thyroid bed. So his thyroglobulin, when he first came to us, was 7.9 and had been slowly kind of trending up for a few months prior to his referral. And we had a long discussion as a group, kind of where to go next. We discussed, would this be most appropriate for repeat surgery? Should we go and try to clean out these nodules in the OR? The surgeon was not very excited about that option, having been in there several times. The last time she went and did sort of a clean out. So there's a lot of scar tissue, very difficult. She was a little bit nervous about nerve injury, going back another time after so much radiation therapy. We talked about potential for immunotherapy, but his oncologist didn't really feel like he was quite there yet in his disease, even though there were some lung nodules that were suspicious. And so we talked about RFA as an option for him, mostly as a way of local control in the neck to control that nodule that was next to the carotid to kind of prevent invasion there, as well as the one along the trachea and the pretracheal tissues, and with similar rationale. So he was excited about that idea, wanted to avoid surgery, and wanted to try something different. And so day of procedure, we did some pre-imaging. You can see again here, right along the carotid, we have our nodule sitting here. And you can sort of see, I think, I don't know the best cine loop of this, but the vagus nerve is actually sitting right here. So very important to have a sense of the post-operative anatomy and how things can be distorted, and being kind of aware of what you're looking for in terms of protecting the nerves as you're working in this distorted anatomy. So here you can see color again. We have the carotid, we have the nodule plaster right against it, and a little hypoechoic eye here is the vagus nerve. So I spent a long time hydrodissecting around this nodule before we started ablating. I did try to push the vagus nerve away with a little bubble of fluid here, D5, and then we also tried to do our best to kind of dissect with the fluid off of the carotid, the nodule, and it took some doing. We took a sort of lateral to medial approach here and kind of came in and were able to work the needle around both sides of this node. And eventually we're able to get a nice plane between the carotid and the vagus to protect the nodule, protect the nerve and the vessel there. And so again, typically we use kind of a transismic, medial to lateral approach here for most of the benign disease, but in this case, we do what we have to do to get the needle in most easily. And in this case, the long axis was oriented something like this. So we kind of came in from this lateral approach. And sort of like Leo was describing, we did a very similar approach. We kind of did 2 passes, less of a moving shot, more of a position and then pull back, but a lower wattage, sitting there for a while, letting the appearance kind of change, watching the impedance move up, and then sort of slowly pulling back to elongate that ablation zone, and then repositioning, doing another pass to get full coverage. And again, here's the vagus nerve that we sort of pushed a little deeper with our hydrodissection. So afterwards, we had a relatively more hyperechoic appearance over the whole nodule. You can see the hydrodissection has dissipated a fair amount here. The limited amount of hydrodissection I've done, I found it to be a little more tricky than some of the videos that I've seen from Dr. Beck. Maybe it's just my technique or my skill. It needs to work on a bit, but it can be challenging, I think, to get a good plane of hydrodissection to form and to really control it. So I found that you need to be pretty quick about moving on to ablation once you have a good margin established around your target. Then we moved on to the thyroid bed nodule, which is quite a bit tougher, a lot harder to visualize, a lot more scar tissue, and the planes were much more difficult to ultrasound well. But you can see sitting down in the scar tissue, there's our target. And so we ended up having to use sort of a funny out-of-plane approach to get to this. Typically, I initially wanted to kind of go from a medial to lateral approach this way, but with the ultrasound and the scar tissue that he had sort of in this region, we couldn't really see the needle tip very well and line things up. So we ended up having to sort of come from a more cranial caudal position here and kind of came in. Here are the borders of the nodule, and our probe is in the middle. And we did a very similar type of two-pass approach. We did a deeper pass and then a more superficial pass to cover the entire node. And kind of a mess in the end. We didn't do too much hydrodissection here. We thought we had enough of a buffer around the trachea and the other tissues to not need to hydrodissect here. And the scar tissue was so thick, I'm not sure we could have really gotten a plane to form very well. But afterwards, our nodule had a little more of a hyperechoic appearance. So we saw him at 1 month. The pictures were a little messy, but much better at 3 months post-procedure, so I included those instead. And you can see here, nodule starting to shrink down next to the carotid. Much more hypoechoic now, much smaller, starting to fade away. And then our nodule down in the area of the pretracheal tissues, again, sort of a little bit messy in the scar tissue. You can see kind of how much fibrosis we were dealing with, but this is starting to involute and get smaller and more hypoechoic as well. So biochemically for follow-up, it was thyroglobulin was about 7.9. Interestingly, as 1 month follow, it bumped up, kind of like we were talking about, this sort of initial increase after the procedure to 10.8, but then by his 3-month visit, it was quite low, less than 0.09, so very, very low at that point. Imaging-wise, at a 3-month visit, we went down to 0.5 by 0.2 by 0.4, so a pretty significant reduction in size in both dimensions for both of these nodules. And so we're continuing to follow him. We've only treated him about 5 months ago, so next month he's coming back for his 6-month follow-up. So some different technical considerations that I learned from this case. Hydrodissection, I think, is important, especially in these recurrences where you're trying to protect adjacent tissues if you're trying to treat these to prevent local invasion or minimize that risk. I think it's important, how much of a margin is necessary? Is 2 millimeters enough? Is 5 millimeters enough? I think you do the best you can to protect the tissues that you're treating. And I think, like Leah was saying, the longer you leave the electrode there in a lower wattage setting, you're going to have more heat dissipation around the probe, and you're going to have more of a margin if you're going to kind of position it a little bit longer there. So you can have a lot of control about how big of an ablation zone you're creating with these systems, which is really nice. And so you may need to have a bigger margin if you're going to do more of that approach, maybe a smaller margin if you're going to use a higher wattage for a smaller lesion. I found, and you need to anticipate the dissipation of the hydrodissection fluid. It will start to run away and can be a little bit difficult to control sometimes. So consider having your electrode kind of in position first and then hydrodissect around the nodules to kind of have them floating with the needle already in place, ready to go. And then stationary versus dynamic ablation, we're a little bit more used in the benign world to doing these dynamic moving shot ablations where we're kind of working our way through the whole nodule and can see very well. With these really small nodules, it's not always possible. With less than a centimeter, you might only have one shot to hit this and be able to ablate it. So consider pulling back instead of doing the moving shot back and forth. You're going to be able to maybe pull back slowly, kind of more like you would laser. Maybe that's a better approach to try. There are a few different adjustable length probes that are coming out now that may be of interest to people. I'd be interested to see the other panelists or moderators how you guys work on matching the probe size to the nodule. Do you like to have the adjustable lengths where you can kind of pick in the middle of the case what you're going to do, or how are you sizing the length of the active tip to the size of the tumor or the nodule that you're treating? Other important considerations, just knowing anatomy, really good ultrasound skills. These can be really difficult patients to ultrasound. Things are very distorted after surgery. We can be missing structures. Things aren't quite where you expect them. So taking the extra time to really orient yourself to all the neurovascular structures in the head and neck that you're wanting to avoid and protect before you start ablating, really important to get comfortable with all that anatomy. Data-wise, there are an increasingly large number of papers coming out supporting the use of RFA for malignancy. Dr. Beck's group has published quite a few. In this paper in head and neck, they looked at 29 patients, 46 recurrent PTCs, and had very good results. They talk about a complete disappearance of the target tumor in about 90% of patients, at about a year out. So looking very promising. Let's see. And again, his same group, kind of a little bit longer series, This was looking at 73 patients, kind of comparing surgery and RFA, and very similar 1 and 3 year recurrence-free survival rates between the two different options. So it seems like there's a definite role for RFA to play here. But some considerations, I think, for us to work on, things to think about, like how do we follow these patients up? Are the thyroid globulin levels useful? How are they useful? How should we be thinking about them and interpreting them? And I think Marius did a great job of kind of discussing that earlier. For us, we've been using every 3 months, kind of post RFA, in line with our ultrasound follow-ups. I'd be interested to see what you guys are doing in terms of following these patients after treatment. And then imaging, we're doing ultrasound, not contrast enhanced, just regular ultrasound to measure the size. Again, this issue of the ablation zone size increasing initially from that margin that you're getting around the tumor, I think is an important concept for people to understand, especially if you're not the ones doing the ultrasounds yourself. You don't want your ultrasound department to kind of get worried and raise the alarm prematurely. But other considerations, I think, for follow-up, things like contrast enhanced ultrasound, we don't do a lot of that here, but it's something that we're looking into, or contrasted CT scans to follow some of these nodules. I'm wondering if you guys have used any of these more advanced modalities for follow-up, or if you guys are just doing ultrasound kind of like we are too. But that's our sort of early approach to treating these recurrent PTCs. Hopefully we have more patients coming down soon to get treated once we get back to doing elective cases, and we can join you guys in doing a little bit more of this kind of work.
Thanks, Tim. I actually was almost as impressed with anything with just your starting, that you guys really have built this core multidisciplinary group. And I think for anybody that's on this call or this meeting, just the idea of having something else in your toolkit that you can turn to, because we all end up, and this was a perfect example with these cases that are just tough, where the surgeon says, puts his finger or her finger on the nose and says, not it, and where else do you turn? And I think your group has really done a nice job of demonstrating that just by having this as an option on the table, patients have the potential for safer and better outcomes.
Yeah, personally, I love having the backup and the support. It's really that concept of loading the boat really helps protect me and makes my life a lot easier to have all those resources to fall back on. So I really appreciate all the help.
Well, we are at 8 o'clock, and we could very easily talk for at least another hour with no slides and no anything else.
We should eventually make the road less traveled #2. John and I
think we should.
Pieces, and I actually have a lot of questions to you, Tim, and I wanted to hear Stan's opinion. I don't think this is metastatic disease to the lung. The thyroid globulin 0.9 does not mean that the patient had mets to the lung.
That was exactly one of my questions. What an impressive response in the thyroglobulin.
Yeah.
It is amazing. So the volume of those lesions was probably a little more than just a couple cubic centimeters to explain a thyroglobulin of 8 pre-procedure. Impressive.
Make #2 because this is impressive. I enjoyed it, guys.
I enjoyed it as well. And Tim, the fact that you were able to go after that one right in the central neck, right next to that recurrent laryngeal nerve with all that scar tissue.
Was harrowing. They were both. Yeah.
Well,
okay.
I love the fact that you commented on you've got to try different approaches, different angles. Do sometimes lateral to medial. You can't just be locked in on how you're doing this.
Russell, I'd like to add that when we're facing these recurrence cases, those are a really different ballgame. We are not talking about those small papillary carcinomas. They're really difficult cases. We should approach them as a surgical case, as difficult as a surgical case. And at this point, we do not have the luxury or the technology that can add up the nerve monitoring. That we are trying to use something new things that will add some kind of tackling or nerve monitoring positioning in order to see that nerve and if the nerve is working and if the structure is actually the nerve. Because as a surgeon, for example, when we have scar tissue and that lymph node is close to the nerve, it's not just a simple 5DW solution that will get rid of those that scar tissue and the nerve from that lymph node. We sometimes need a scalpel to clear that nerve. So it is a really tough decision when we face this kind of nerve and we opt to ablate that nerve. We have to be really aware that we can damage that nerve, and the patient really needs to be advised that surgery, we can damage the nerve, but we can damage the nerve knowing that we are damaging the nerve. And although the radiofrequency ablation is way less invasive than a surgery, we do not always know where the nerve is, or the nerve is crossing all that lesion. So it's still a work in progress. And that that electrode that changes the length of the active tip, I don't know if in the US you have it, but the probes that I use it are a little bit wider than the ones that we use in the regular ablation for those small nodules. So when sometimes it is harder to stick that larger needle into a small lesion in order to adapt the length of this lesion. But technology, we actually have an electrode that has just one side that ablates. We have one side that is coated and one side that you only one side ablation. So you can approach that kind of ablation on 180 degrees of ablation in order to spare the area that you think the nerve is there, and try to minimize the chances of having a nerve damage. So all this is going to change in the near future. A lot of new technology will aid us in better ablation, definitely.
Well, thank you all for logging in this evening. Thanks to all of our guests, and especially thanks to our panelists for being on here. On behalf of the North American Society of Interventional Thyroidology, everyone have a wonderful evening, and
Have a good one.
thanks Dr. Kuo for putting this together. Imad, stay safe down there, man.
Bye, buddy. See you.
I don't want to see your picture looting some CVS store somewhere.
Okay.
See you guys. Great to see you.
See you.
Be safe. Bye-bye.